neurosurgery internship and applying in neurosurgery. And as you can see here, she's been very productive in research. She's got 18 publications. And today she's going to talk to us about laser interstitial thermal therapy.
Thank you, Dr. Kellner. All right. Can you see my presentation?
Yes, we can.
Okay. All right, good morning, everyone. I'm Jenny, and I'm an intern rotating on the service. I will be talking to you today about laser interstitial thermal therapy, or LIT, in the management of brain tumors, and some things we have learned over a decade of experience. So since LIT is a relatively new technology, I wanted to start by taking a brief look at this technique and what makes it suited for brain tumor management. The current treatment paradigm for malignant brain tumors is a combination of maximal safe resection and adjunctive therapies, including radiation and chemotherapy. Some challenges with the approach, however, include the fact that gross whole resection is sometimes not possible in deep-seated tumors or tumors that are close eloquent areas. Furthermore, these adjunctive therapies are often insufficient at reducing tumor burden in comparison with surgical resection. And that is where something like LIT comes in. So LIT provides a minimally invasive method of ablating specific targets in a process known as photocoagulation, which is essentially cooking the tumor. So as we can see here, we insert the laser probe into the tumor bed.
I don't know if it's me, but I lost audio there.
Can you hear me?
Yes, now I can hear you. Yep.
I'm sorry, my internet has passed out for a second. LIT provides a good alternative for patients who are not candidates for conventional surgery, either due to anatomical constraints of the tumor or functional constraints of the patient. It also provides a method for further cytoreduction after resection. So I wanted to show this brief video that shows the process of LIT. So as we can see here, the laser is inserted into the tumor bed. It is then fired to cook the tumor. This shows the MRI thermometry that we use intraoperatively. Depending on the size of the tumor, more than one trajectory might be necessary to achieve complete necrosis of the tumor bed. So this schematic provides a viewing of some of the equipment that we use in LIT, including the fiber optic probe, as well as a diode laser. And then this procedure is often is done in an intraoperative MRI suite. So preoperatively, we obtain volumetric MRI sequences of the patient's brain, and regions that are defined include the tumor or area of the interest, as well as the entry point and the trajectory that we want to take before the procedure. So LIT results in 3 histological distinct zones of thermal damage that are marked by TDT lines or thermal damage lines. Now, these lines basically show different regions of the tumor and the tumor and the amount of cell death that occurs in each region. And what gave rise to this actually is the Arrhenius equation, which predicts cell death as a function of 2 things, tissue temperature and ablation time. Now in practice, this is already integrated into the software and algorithms, but this is where the etiology comes from. So intraoperatively, we have 3 zones. Zone 1, outlined by the blue line, is the area closest to the probe, and this area achieves complete necrosis. And it's basically equivalent to the cells here get equivalent energy of 10 minutes at 43 degrees Celsius. Inside the yellow line, outside the blue line, this is the intermediate zone, and cells in this area undergo possible necrosis. And basically, they receive the amount of thermal energy equivalent to 2 minutes at 43 degrees Celsius. The marginal cells outside the yellow zone may be damaged, but they remain viable. So the rationale for our study is that, like all new technologies, LIT comes with a learning curve, and the Cleveland Clinic was one of the earliest adopters of the technology, and as such have one of the largest cohorts of patients to date. So some things we wanted to look at and describe were what we learned about LIT in terms of patient selection, surgical approach, and tumor profile, and postoperative outcomes. So to do this, we basically retrospectively reviewed all patients who underwent LIT for brain tumors from 2011 to 2018. We excluded procedures that were aborted, and patients were classified into two time periods, including early from 2011-2014 and late or recent from 2015 to 2018. We performed data collection, including patient parameters, surgical parameters, as well as follow-up data. And we performed statistical analysis to basically look at two primary endpoints, basically survival and functional outcomes of the patient. So as a brief overview, we see that in terms of patient selection, the vast majority were for gliomas, whether it was high grade or low grade. There was also a portion of the patients that underwent LIT for radiation necrosis, and a small proportion underwent LIT for metastasis. Looking at the tumor profile over time, we do see a shift from using lead for gliomas to using it more for radiation necrosis. In 2018, at the time of this study, we stopped the study in the middle of 2018, and that is why there are fewer patients here. So looking at our results, the patient demographics were essentially the same in both cohorts, with the exception of age. And one explanation for this is that initially, when we first adopted this technique, we were very careful. We chose more younger, healthier patients with better prognoses, whereas in the more recent cohort with more experience, we expanded patient selection to include a broader range of patients and prognoses. So some things that we found were that in the more recent cohort, there were greater laser coverage and efficiency, which resulted in reduced operative time in the recent block, as well as a decreased number of trajectories in the recent block. And this correlated pretty well with the new generation of laser systems that was introduced at our institution in the middle of 2013. We also found decreased motor deficits, permanent deficits in the recent block. As we can see, it was in the earlier time period, there were 15.5% of patients that had permanent motor deficits compared to the 4.4% of patients who had permanent motor deficits in the more recent block. There were no statistically significant differences in temporary deficits, however, between the two time periods. Now, the outstanding question then is what accounts for this difference? What changes did we make to decrease the number of permanent deficits in the more recent block? So the answer comes from some preliminary analysis that we performed in 2014, which basically demonstrated that overlap of hyperthermic fields with motor areas were correlated with an increase in permanent motor deficits. So as we can see here, we see that even a small overlap of hyperthermic fields with cortical spinal fibers is correlated with unfavorable outcomes, which makes sense anatomically as well as functionally. So taking this knowledge, we started actually tracing out and uploading the cortical spinal fibers into our image guidance software, and we took care to make sure that those fibers were outside of the yellow line and therefore remained viable. We also noticed a clinically important reduction in complications, including large hemorrhage necessitating surgery, as well as 30-day mortality. Now, it's important to mention that given the novelty of this technique, our study was not powered to detect any significant differences in these clinically important complications. One question I had was the effect of tumor and patient profiles, especially tumor size on outcomes. So in terms of tumor profile, we see that LIT in our institution was being used more frequently for radiosurgery throughout the years. And one explanation for this also comes from some work done at the institution that basically showed that LIT had a very good outcome for patients with radiation necrosis. So in this multi-center phase 2 study of LIT with 6 centers across the US, we show that patients with radiation necrosis that were treated with LIT had 100% PFS at 2 weeks and 90% PFS at their last follow-up appointment. One of my interests was looking at tumor size and how LIT worked for tumors of different size. So what we found was that smaller tumors, which were defined by tumors that were had a volume less than 4 centimeters cubed, had a statistically significant longer overall survival at 12 months, 18 months, and 24 months compared to their larger counterparts. So one explanation for this is that smaller tumors are more likely correlated with greater laser coverage. And this is consistent with the work that we have done previously at our institution. We also found that smaller tumors had a significantly longer PFS than larger tumors in LIT for patients with high-grade gliomas. As I mentioned previously, work done at the institution have shown that smaller tumors have more favorable 3D coverage and thus are better coverage by the thermal energy during intraoperatively, and that tumors with more favorable 3D coverage have improved overall survival and PFS survival as shown here. The last question that I wanted to address in this study was functional outcomes. While survival is obviously very important for these patients, their quality of life is another major consideration. So what we found is that compared to patients with KPS scores or Karnofsky performance scores at or above 70, patients with subpar KPS scores defined as between 50 and 70 had greater number of permanent deficits following the procedure, as well as decreased overall survival at 12 months, 18 months, and 24 months. There was also worse PFS, but this did not achieve significance. So in conclusion, we found that the improvement in device technology and surgical planning resulted in a reduction of both operative time and the number of trajectories in the more recent cohorts. Importing critical fibers into the image guidance software allowed us to keep them outside the zone of thermal damage, and that led to a significant decrease in permanent motor deficits in the recent cohort. Smaller tumors is correlated with longer overall survival and progression-free survival in patients with high-grade gliomas. And poor preoperative KPS scores, so patients with poor functional scores preoperatively were associated with more permanent motor deficits and decreased overall survival. As such, laser ablation may not be very helpful in this group of patients. And lastly, based on outcome analysis, there's been a trend towards using LIT for smaller tumors, utilization of LIT in radiosurgery, and a decrease in infection, massive hemorrhage, and mortality due to better patient selection and surgical approach. I want to thank my mentors, Dr. Mohammadi and Barnett, as well as all my co-authors for their mentorship and help on this project. And of course, I want to thank the Mount Sinai Neurosurgery team for a wonderful month. And I will take any questions. Thank you.
Jenny, nice job. Really great presentation on LIT and really enjoyed that. I had a question for you. So, LIT was originally described for use in recurrent tumors, which you highlighted. And, it's evolved in its application to radiation necrosis and now newly diagnosed tumors. Let me know your thoughts. I mean, what do you think about using this up front in a newly diagnosed patient when we have other treatment modalities? Are there certain tumors that we should look at in particular for LIT in comparison to other treatments we have?
For sure. So I think one thing that I've, learned from this project is that while LIT was, kind of first utilized for brain tumors, especially like recurrent brain tumors, I think just by like the nature of kind of the pinpoint nature of LIT, I'm not sure that it is most suited for brain tumor management, especially very large brain tumor management. I think it is much more well, especially in the literature, for cases like epilepsy or cases that require more pinpoint like pathway disruptions in terms of patients with like any tumor, depending on the size of the tumor, you would require multiple trajectories. And at that point, I believe surgical debulking might be a better option. I was actually just in a case with Dr. Panoff yesterday, utilizing LIT for epilepsy, and I think that's definitely a really promising indication for LIT.
By the way, we have a laser symposium at 11 a.m. today with the Society of Neuro-Oncology. Everybody's welcome to join us. LIT's going to be highlighted on there, so please join it.
Thank you.
Good job.
That was a great talk. Can someone talk about what is the rationale for lesioning a radiosurgery-induced or radiation-induced lesion?
Thank you, Dr. Batterson. So I think at least like in the study, what in the beginning it was a new technology, so we basically tried to utilize it for a variety of tumors as well as radiation necrosis, kind of just to see what it would be more effective in. And it kind of just happened that what we found was that it was very effective in radiation necrosis and not as effective in patients with large tumors. And then that's kind of explain the trend towards using it for radiation necrosis.
Costas or someone who can help, can you help understand what's happening there, if that's a real thing? How can a lesion on top of what is the concept of a lesion for a lesion?
Well, so the way, and let's be honest here, I think the science is kind of forthcoming still. It's not really hammered out, but I think, you know, the concept is because radiation necrosis is an inflammatory process with a recruitment of cells and edema, breakdown of the blood-brain barrier, you know, the heat itself kind of ablates that area. Now, you could argue that there could be more edema that can occur with hyperthermia treatment, which is true. But in the case of radiation necrosis, it really, really helps. And, you know, we've had a number of index cases here where the treatment occurs within a minute. The heat, you know, basically transfers to the entire volume of the tumor. And then our outcomes afterwards are pretty impressive. So it's a real phenomenon. And actually, it's our go-to for larger radiation necrosis volumes that we need to treat. Of course, Avastin is something that we also use, you know, in those cases. But, you know, it's something that we need to study more in terms of the science, JB, to kind of understand, you know, the mechanism.